Okay, the first question on esophagus, right? Esophagus, SCQ, asked in KO is right short note on normal, right? Normal anatomical constriction in esophagus, right? Esophagus. Now talking about the normal anatomical constriction in esophagus, what we have, right? Three constriction in this special three constriction, right? Now what are the three constriction? The one is 8 pharyngoesophageal junction, and this pharyngoesophageal junction is 8, how many distance? It is 15 centimeter distance from what? Our upper incisor. Now why we are taking upper incisor as reference? Because the upper incisor is not mobile, it is immobile, since the lower incisor are mobile, so we take distance from upper incisor. So from upper incisor, the pharyngoesophageal junction, the first constriction, as you can see, narrowing, that is at what? 15 centimeter. And another is what? At the bifurcation of crossing of arc of aorta and our what? Left main bronchus, right? Left main bronchus, as you can see, it is at the level of bifurcation of what? At the crossing of our this left bronchus and our this arc of aorta, and it is at what distance? It is at the distance of 24 centimeter from our upper incisor. Similarly, the third constriction is, where is our third constriction? The third constriction is where our this esophagus, right? Our esophagus now what? Pierces our diaphragm, right? Where it pierces our diaphragm, as you can see here, it is piercing our diaphragm. Now at this level there is another constriction, and it is what? It is 40 centimeter from our upper incision. So we are clear, I think. The one is what? The pharyngoesophageal junction, another is the crossing of arc of aorta and left main bronchus, and another is the place where our this esophagus pierces, right? Pierces our diaphragm, that is at what? T10 or 40 centimeter. And distance is also important, 15 centimeter, 24 centimeter, and 40 centimeter. The same thing is written right here, as you can see, right? As you can see right here. So these are what? These are the normal anatomical constriction in esophagus. Now another question that is asked from esophagus is, what are common, right? Common foreign bodies in esophagus of adult, right? Adult. And another is, what are the specific investigation, right? What are the investigation in needed in such case in foreign body in esophagus, and how will you manage, management of such case? Now talking about common foreign body in esophagus of adult, the most common foreign body are what? Talking about the most common body, they are what? They can be bones, right? Bones of meat, right? Meat, we can say bone of fish, right? We can say meat itself, right? Meat itself, where you can say, and these are what? These are the common foreign body in esophagus. We can say nail, right? Nails, small nails, right? Nails accidentally that may get into esophagus. These are also what? These are found most commonly in adult. And talking about what? Children. Now in children, what we can say? We can say coin, right? We can say coins, we can say battery. Similarly, the coin, batteries, we can say what? The hair clips, small hair clips that can be accidentally ingested by children. Similarly, hairpins, right? Hairpins, these are what? These are the common foreign bodies. Now talking about what? Now talking about what are the site of lodgement of foreign body? Now since we have already mentioned, we are here in question of esophagus, the other site are our tonsil, the base of tongue, posterior pharyngeal wall, piriform fossa, right? And esophagus itself. Now another question was, what are the essential investigation, right? Investigation in the case of foreign body within esophagus. Now talking about the most the most important investigation, right? The most important investigation that we do is the cheap one, the most important we do is x-ray. Now in x-ray, what we can do? In x-ray, we can we can have two view. One is lateral view, right? We can say that as soft tissue lateral x-ray of neck, right? And another is soft tissue anterior posterior, right? X-ray of neck, soft tissue lateral x-ray of neck and anterior posterior of neck. And another what we can do is, now what is the difference, what is the importance of these two view? And another what we can do is, we can have another view also, and that is our anterior posterior or the lateral view of chest also, right? The anterior posterior lateral view of chest also. X-ray of chest. chest also can be seen. Now the importance of this soft tissue x-ray lateral and AP view is that we can because of these things, because of this lateral and AP view, we can differentiate the place of lodgement of our foreign body. Either it is placed in esophagus or in trachea. If it is placed on esophagus, as you can see right here, in food pipe, food passage, or in esophagus, what we can see is in AP view, right? In AP view we can see circular, right? Circular pattern, right? Circular pattern. And in lateral view, what we can see is we can see slit like, and opposite goes in if there is foreign body lodgement in what? In trachea, right? So what I'm saying here is this is the condition in which the foreign body is lodged into what? Into esophagus. And if it lodged into trachea, then opposite will happen. That means in AP view we will see slit like, and in lateral view we will see what? We will see circular pattern. And this occurs because of what? This occurs because of placement of the orientation of what? The vocal cord, right? The vocal cord. And another is because of what? Because normally esophagus remains in constriction. Normally it constricts. The normal the position of esophagus is the constriction phase, and when we ingest food, at the time it dilates. So that was X-ray. Now talking about these X-ray, what we are doing here is, right, we're talking about plain X-ray. Now if there is what? Radio opaque object. If radio opaque object, we can clearly see it in the X-ray, right? There will be whitish appearance. But if there will be radiolucent, then we are not very clearly able to see those foreign bodies. So what we do is, if there is radiolucent, what we do is we just do fluoroscopy. Fluoroscopy. Now what is fluoroscopy, right? The radiolucent foreign body are not seen on X-ray. So what we do is we give a piece of cotton soaked in barium, right? Barium. Now since the barium is radio it is radio opaque, it can be seen clearly. So what we do is we give a cotton piece soaked with barium, and when the person ingests it, at the time we can see what? Radiolucent foreign body also. So the first two investigation what we can do is, we have already mentioned, we can do X-ray, right? The importance of X-ray in finding out the position, either it is in trachea or in esophagus, we have already known it. And another is what we can do is we can do fluoroscopy. Fluoroscopy is, after doing fluoroscopy we do X-ray only, but fluoroscopy we do it for radiolucent object. Now okay, these are the same thing is mentioned right here. Now talking about the management, we talked about investigation and management. Talking about management, what we can do is, the first thing is we can do endoscopic removal, right? Endoscopic removal. And it is also our oesophagoscopic removal, right? Mainly rigid and flexible oesophagoscope are present there. We can do it simply like this. And what will happen if there will be our sap, the foreign body with sap hooks, right? Hooks. At that time what we can do is we can't take risks of doing endoscopic removal. What we'll do is we'll open esophagus, right? We'll do what? Esophagostomy, right? You can see esophagostomy, right? We'll do esophagostomy. Now esophagostomy are also of two types, depending upon the level where we are doing it. If we are doing at the level of cervical esophagus, it is called cervical esophagostomy. And if we are doing it at the level of thoracic level of esophagus, then we call it a transthoracic esophagostomy, right? Now cervical esophagostomy and transthoracic oesophagostomy, what is difference between them? Talking about cervical oesophagostomy, right? If the foreign body, I have already mentioned, right? Oesophagostomy, we are doing it because the foreign body that is getting lost is what? It is sap, right? It is dentated. That's why we are not taking risks of doing endoscopic removal. So talking about cervical oesophagostomy, it is done, right, at the cervical level of esophagus, right? And what is that actually? That is the place if foreign body is placed above thoracic inlet, right? If the foreign body is above thoracic inlet, or if it hasn't crossed thoracic inlet, at that time what we do cervical oesophagostomy. And if the foreign body has crossed thoracic inlet, right, and it has entered into thoracic esophagus, at that time what we do is we do transthoracic oesophagostomy, right? Now what will happen if it has passed that level also, and if it has reached into pylorus of stomach? In such case, it will pass through a rest of gastrointestinal tract, right? And and it will be passed out in stool in after some days, and we need to carefully examine stool for 3 to 4 days, and we need to watch out if it has passed or not, right, and it has spontaneously passed or not. Now and in such case, the individual is not suggested to take purgative, right, for to hasten the passage of stool, so there is no importance of giving purgative. Now there are other operative interference also. Now when we do operative interventions, now we talked about what we talked in management, talked about endoscopic removal, right, endoscopic removal. If the object is foreign body is sap, right, it is dented, it is sap, it consists of sap hoop, then we do oesophagotomy. And oesophagotomy also are of what two type, depending upon the level, cervical and transthoracic, right. If it hasn't crossed thoracic inlet, then we do cervical oesophagotomy, and if it has crossed thoracic inlet, we do transthoracic oesophagotomy, right. And if it has already passed the pylorus of stomach, then we just watch it till it what spontaneously pass it spontaneously if it is expelled from our stool. Now what are the criteria in which there will be operative interferences, right? If the patient complain of pain and tenderness in abdomen for so long, or if it is so intense, then we can do operative interferences, right? If the foreign body is not showing any progress on periodic x-ray, right, at few days interval, if on doing x-ray at periodic days interval the foreign is not showing any progress, right, if it is not improving, then we can do. If the object are sap, right, and if it is likely to penetrate or get obstructed, example nail, pins, needles, sap bones, right, dentures, fragments, razors, or long thin wires, if the object are so sharp that there may be risks of penetration, so what we do is we don't wait, we just do operative interferences. Now if the foreign body is 5 centimeter or longer, like hairpins, right, in child of 2 years, it is unlikely to pass through the torn of duodenum, right, it is very unlikely to pass to expulse through stool, so we just do operative interventions. And similarly, or Dick's battery larger than 1.5 centimeter in child of 6 years, remaining in stomach for 48 hours, in that also we just do what, we do operations, and if there is pyloric stenosis in that case. So we are clear about what two questions. One is what are the common constrictions of esophagus constriction, and another is what are the common foreign bodies in esophagus, what are the investigation, and what are the management protocol done in the case of foreign body in esophagus. And that's two questions asked in KU of esophagus ENT exam.